Good morning, dear students. Today, I'm going to talk about two important topics in gynecology. First is amenorrhea, and second, other abnormalities of menstrual cycle. And in those, we'll mainly talk about menorrhagia, okay, polymenorrhea, oligomenorrhea, dysfunctional uterine bleeding, metrorrhagia, and postmenopausal bleeding. So these are a little bit, rather I say difficult topics from gynecology, but in clinical practice a lot of ladies they present to the hospital with this problem. Okay, so let's pay attention. Let's start with the topic of amenorrhea, very important one. Now amenorrhea, you all know, is absence of menstruation. Absence of menstruation. So this amenorrhea may be normal for certain ages or certain period. For example, before puberty it is normal, after menopause it is considered normal. Okay, and even during pregnancy it is considered normal. But apart from them, if a reproductive age group female develops absence of menstruation, then we have to investigate for it what is the cause, and this is known as amenorrhea. Now let's enter into the topic. Amenorrhea is the absence of period or menstruation. Okay, absence of menstruation. It is a normal physiological event before puberty, during pregnancy, even during lactation, and after the menopause. In this situation, it is considered normal physiological event. Now, during lactation, remember that prolactin hormone, which is actively releasing from the anterior pituitary gland, okay, this hormone doesn't allow the normal menstruation to occur. But this is a highly, controversial statement, or we cannot really, rely on it, rely on the total lactation for contraception, because even for 1 to 2 days, if the lady doesn't breastfeed the baby, then she can get pregnant. So we cannot completely rely on lactation for the contraceptive effect. Okay, we have to explain this point to that female. Now there are two types of amenorrhea: primary amenorrhea and secondary amenorrhea. This is a classification. Primary amenorrhea means the lady has never developed any period. Okay, there is no menarche. It is the absence of menses in women who have not undergone menarche by the age of 16. So no menstruation by the age of 16. The absence of menses at age 14 without secondary sexual development, or age 16 with secondary sexual development, is called primary amenorrhea. Now see there. So she has already developed, secondary sexual characteristics, but still there is no menses. We can wait till the age of 16 for the definition. But no menses and no secondary sexual characteristics, when she reaches age 14, we can label her as a primary amenorrhea girl. Now, can you tell me one? There are so many causes, okay? Just one cause of primary amenorrhea which you have studied many times. Yes? Anybody?
Sir, the presence of ovarian cysts.
Okay. Turner syndrome is the perfect answer here. Turner syndrome. Okay. There are so many other. We'll come to that discussion. But Turner syndrome is definitely one of the cause which leads to primary amenorrhea in that girl. Now, secondary amenorrhea means it's the absence of menses for more than 6 months in a woman who previously had menstrual cycle. So everything was fine before, but because of some reason, she stopped, okay, having the menstrual cycle. That is called secondary amenorrhea. Cryptomenorrhea is another one. Cryptomenorrhea, it is not exactly the amenorrhea, but the lady is menstruating, but we cannot see any bleeding from outside. Crypto means hidden. Now, this is used to describe those ladies who are menstruating, but in whom bleeding is concealed or hidden. For example, in case of imperforate hymen. Now, imperforate hymen means hymen, okay, uh, is not perforated, means the external vaginal opening is closed by the hymen. So how can the menstrual blood flow outside, isn't it? It cannot. Now what will happen? It's quite interesting one. So that menstrual blood will remain inside. First, it will fill the vagina. Okay, it will fill the vagina. This condition is known as hematoculpus. So let me write it here. Hematoculpus. Now, after that, it will fill upwards, isn't it? It will go upwards. It will fill the uterine cavity. Uterine cavity. This condition is known as hematometra. Hematometra. See that. Now, this type of uterus will present as a mass, isn't it? Will present as a mass. When we do bimanual examination, we can feel this enlarged uterus. Actually, this uterus is filled with blood, and this is commonly seen in young girls. Okay, because they started to bleed, but the blood is not coming out, and the cause is imperforate hymen. So after the diagnosis, treatment is very easy. You just give cruciate incision to the hymen. You just open that hymen or remove that hymen, and large amount of collected blood will come outside. And from the next, menstrual cycle, everything will be fine. This is known as cryptomenorrhea. Let's move on. Now, let's talk about what are the etiology of amenorrhea. The first type of causes are anatomical. Now, anatomical causes. So let's talk about the congenital causes and acquired causes together. Now, the congenital causes are intersex state are the most important one. Like these are the endocrine disorder where, okay, uh, where both sexes are present in a single person. If it is there, we call it true hermaphrodite. Means both types of gonad are present in a single person. Like the person is having ovaries as well as testes, and this is known as true hermaphrodite. And the incidence of true hermaphrodites are rare these days, but the pseudo hermaphrodites are very common. Pseudo hermaphrodite. Now, this is a very interesting field of the discussion. So let me give you some important points right now or concept right now. Now, pseudo hermaphroditism are of two types: male pseudo hermaphroditism or female pseudo hermaphroditism. Now, what is the meaning? The genetic sex is different and the phenotypic appearance is different. Okay. Now, how we give the term here? Male pseudohermaphroditism means genetic sex is male. Now, what type of genome is present in male? What is the genotypic sex of male? Yes. What is that?
X1.
Exactly.
X
Exactly. Presence of Y chromosome. You are very, very true. Right. Presence of Y chromosome. So that is present when we analyze the chromosome. But the external appearance is like a girl. So this is known as male pseudohermaphroditism. Whereas if the genotypic sex is female, that is XX, but the external appearance is like a male, we call that female pseudohermaphroditism. There are different causes for that, okay? We are going to talk. One of the important causes is congenital adrenal hyperplasia. See this. You will study this in endocrinology of internal medicine. Congenital adrenal hyperplasia is a condition, is mainly autosomal recessive disorder which runs in the family. In this condition, 21 hydroxylase is the enzyme which is deficient most commonly. So there will be no synthesis of glucocorticoid and no synthesis of mineralocorticoid. But there is excessive synthesis of sex steroid. Sex steroid. Now think about the situation. If this is a baby girl, okay, and that baby girl is predisposed to large amount of androgen early in the life. Now the external genitalia looks like male baby, but she is a female baby. by genotypic sex. So this is known as female pseudohermaphroditism. So this is one of the good example we can give here. So there are lots of people who present like this. Second one is a malformation of the female genital tract. See there. If there is some problem with Mullerian duct development, if there is a Mullerian agenesis, then this type of disorders are quite common to occur, like uterine agenesis, vaginal atresia, imperforate hymen, okay, and if Mullerian agenesis is the cause, then it is responsible for about 10% of the primary amenorrhea cases, and we cannot do much regarding this. Regarding the acquired anatomical causes of amenorrhea, there are endometrial fibrosis, which is known as Asserman syndrome. Asserman syndrome. Now, this Asserman syndrome is the term which we use if there are multiple, scar formation inside the uterine cavity, and the wall of the uterus are stick with each other. So, what will happen now? The uterine lumen will be very narrow. Uterine lumen will be very narrow. This is known as Asserman syndrome. Or you can remember like this, there is lots of adhesion formation inside the uterine cavity. Now, why this condition developed? Because of repeated trauma to the endometrium or the wall of the uterus. Think about some surgeries which we do in the uterus. Now, what are the surgery we do in the uterus? Can you name few of them? Which surgery are done in uterus? Yes? Yes, yes. They are dilatation and curettage. That is one, very easy. Dilatation and curettage. We curate the uterine cavity or endometrium. Another is caesarean section. We have studied that already. Okay, caesarean section. Third is myomectomy. Remember the treatment of fibroid. Myomectomy. We remove the myoma. So uterus is again damaged. And hysterectomy, the total removal of the uterus. But in hysterectomy, there is no chance of Asserman syndrome, isn't it? Because you have removed the uterus. I'm just asking, what are the surgery you do in uterus? So you can answer like that. Let's come to the point now. Asserman syndrome develops when there is repetitive, okay, trauma or damage to the uterine cavity, like myomectomy, like repeated dilatation and curettage, even after a caesarean section, or some of the very severe infection of the endometrial cavity. So there is development of adhesions between the wall of uterus, resulting in Asserman syndrome. Now, if some lady is suffering from Asserman syndrome, then they may become infertile. There is a problem in the menstrual cycle, okay, and problem, uh, like for example, even the cervix may get narrowed there, even the menstrual flow will be a problem. So this is known as Asserman syndrome. Tuberculosis is another condition which can lead to Asserman syndrome or endometrial fibrosis. Now, cervical stenosis is a definite cause of amenorrhea, because uh, the menstrual flow cannot come. Rather than complete type of amenorrhea, I will label this as a cryptomenorrhea, because endometrium is fine, probably it is shedding downwards, but the uh, visible type of blood is not coming down because of stenosis of the cervix. This usually occur due to surgery on the cervix, especially cauterization or conization. This is also a type of scar formation there. Now, what are the endocrine causes of amenorrhea? Now, see there are so many. Many endocrine disorders can cause amenorrhea. The most common causes are functional disorders of the hypothalamus and hyperprolactinemia. See here. Okay, hyperprolactinemia and functional disorders of hypothalamus. Now, we have talked a lot about hyperprolactinemia before also. Prolactin acting a bit of antagonist hormone for estrogen. And hypothalamus releases, GnRH. That GnRH is stimulating the release of gonadotropin from the anterior pituitary. So you got the idea already, why uh, a lady can have amenorrhea in this type of situation. Now see there, these are the hypothalamic disorders. Hypogonadotropic hypogonadism, also known as Kalman syndrome. Okay, one of the example is Kalman syndrome. Hypogonadotropic hypogonadism. Now, can you explain what is the meaning of this hypogonadotropic hypogonadism? Anybody?
Sir, like there is a delayed or absent puberty in a female, sir. We can say, like in a sense.
Okay. Now see there. The meaning is quite simple, isn't it? Gonadotropic hormone are FSH and LH. So they are getting lesser, or they are getting decrease in the blood. Now, when they are decreased, they cannot stimulate the female gonad, that is ovary. So the hormone which are released by ovary, those are estrogen, okay, especially estrogen and progesterone as well, are decreased again. So this is known as hypogonadotropic hypogonadism. In male, there is decreased testosterone. In female, there is decreased estrogen. So as a result of this, the secondary sexual character are not developed. Okay, are not developed. The puberty doesn't occur. All those things happen at the time of puberty are not happening. And another very, very important point in Kalman syndrome is anosmia. Okay, anosmia. Now, what is anosmia? Okay, anosmia means, yes, it is lack
Sir,
of,
anosmia, sir.
yeah, yeah. What is that?
Uh, smell, sir, smell.
Exactly. It is lack of smell. Okay, lack of smell.
Sir,
Yes. Anosmia, like lack of smell. So this Kalman syndrome also, causes some abnormality in the smell center, okay, uh, which is present in the hypothalamus. So that is a problem here. So it is one additional features along with hypogonadotropic hypogonadism. We'll talk about that. Another cause is psychogenic. It is associated with emotional stress. It's a very interesting one. If a lady is, emotionally disturbed, for example, her daily routine is, change. Okay. For example, a female doctor, a young doctor, or a nurse. Okay, because we are from the medical fraternity, so I am giving that example. Okay, so if she is a lot of giving a lot of time to the hospital, she is not able to sleep, for 2 to 3 days continuous type of night call, night duties and things like that. If that is happening for a longer time, then she may become amenorrheic. This is the effect of emotional stress. So we call it psychogenic type of amenorrhea. But after some time, when she comes back to her routine, daily life, everything will come back to the normal. And a lot of cases are presented like that. Excessive exercise and excessive weight gain or even weight loss can result in amenorrhea. One of the good example we can give is anorexia nervosa. In anorexia nervosa, there is excessive weight loss. This is another type of psychiatric disorder. We call that eating disorder. Okay, there are two types of important types of eating disorder: anorexia nervosa and bulimia. Now, in anorexia nervosa, the girl, which is very common in girl, okay, or female, that female or girl thinks that she is too fat, or her overall appearance of the body is not good because of deposition of a lot of fat. But she is absolutely wrong. This is a sort of perceptual defect. She is not fat, she is already lean and thin, but she thinks like that, and she avoids eating. She avoids eating. She just eat that amount of food which will keep her survive. Okay. So over a period of time, she becomes very lean and thin, and she becomes ill because of this. Prime amenorrhea also occur, along with so many other, like immunodeficiency state will develop. This is known as anorexia nervosa. We'll study this in psychiatry. This is a psychiatric condition. Whereas bulimia means it is again common in female. So that female is a little bit obese or overweight already. But what happens is she cannot control eating. Whatever food she food is kept in front of her, she quickly finishes that. This is known as binge eating. Large amount of food is eaten at a time, and after that she feels regret. Oh, why did I eat so much food? Now I'll gain weight, or I'll become fat. She thinks like that, and she will try to vomit it out. Usually what happens, they'll put the finger in their oral cavity and they will tickle the posterior part of the pharynx, and they'll try to vomit it out. So this is called bulimia. Okay, these both conditions are known as eating disorders, and they are associated with endocrine problems like amenorrhea as well. Infections like tuberculosis and syphilis, if it damages the hypothalamus. Chronic disease like diabetes and even AIDS or HIV infection. Tumors like craniopharyngioma, which occurs in that region of pituitary gland. Craniopharyngioma develops from the remnant of pituitary gland, which is known as a rat cage pouch. Let me write that term for you because it is important question in your future exam. Rat cage pouch means from rat cage pouch, anterior pituitary gland is developed. So if the remnant of rat cage pouch still exists there, they may develop into a tumor. It's a benign tumor, which is known as craniopharyngioma. Post-oral contraceptive use, that means after the use of oral contraceptive, amenorrhea may develop. This is known as post-pill amenorrhea. So these are some of the endocrine causes. Okay, try to remember a few of them. Now, others are the pituitary lesion. We talked about the hypothalamus. Now, let's go to the pituitary. Tumors are the number one pituitary diseases which can result in amenorrhea. They may occur with or without hyperprolactinemia. Now, all of them may not be associated with hyperprolactinemia, but many of them are. They include prolactin secreting pituitary adenoma, non-functional pituitary adenoma with supracellular extension, which impair blood flow down to the pituitary stalk, and growth hormone secreting tumor. Now, probably this type of discussion is a little bit difficult for you, but I will try to give a concept here. There are two types of pituitary tumor. One is called functional, another is non-functional. Non-functional means they don't release any hormone. They are just mass there, but they can also do damage because of the pressure, because of the necrosis, pressure necrosis we say, because of the impairment of blood flow. So they are equally damaging there. And another one, functional, means they release some hormone, and with the effect of the hormone, they produce sign and symptoms. Now, another term is Shihan Syndrome. Now, you are quite familiar with this. What is Shihan Syndrome, by the way?
Sir, hypopituitarism, sir, basically it is.
Hypopituitarism because of what? Because of what? What reason?
Sir, because of ischemia, sir, loss of blood supply.
Exactly. Now you have to add that, okay? Yes. Shihan syndrome is a hypopituitarism because of relative ischemia of the pituitary gland, which occurs during pregnancy. Now, during pregnancy, pituitary gland is hypertrophied. It becomes big. And after the delivery, during the third stage of the labor, if there is excessive hemorrhage, which is known as postpartum hemorrhage, now there will be relative hypovolemia in that lady. So pituitary gland may not receive enough blood flow, which results in necrosis of the pituitary gland. That is known as Shihan syndrome. Don't forget, very important question from the exam point of view. Granulomatous infiltration in the pituitary can also damage it and results in amenorrhea. One of the example is neurosarcoidosis. Why the term neuro is there? Because it is involving the central nervous system. And pituitary gland, though it is not a part of central nervous system, but it is present inside the cranial cavity in the sella turcica. That's why we use the term here. Now, one small question before I move further. Why the lady develops amenorrhea when pituitary gland is damaged? Why? Yes, what's the reason? What is the function of pituitary gland in the maintenance of menstrual cycle? That's the question. Yes, what pituitary gland is doing there? It is releasing FSH
Sir,
and LH.
because the releasing of the hormone, neutrophilia hormone. Yes.
Yeah, exactly. It is releasing the hormone FSH and LH, and those hormones are absolutely necessary for the maintenance of a hypothalamic pituitary ovarian axis. That is the answer you can give. It's a very easy one, okay? And sometimes they release different other hormone which are antagonizing the effect of estrogen. Now, what are the ovarian lesion and other endocrine lesion that can result in amenorrhea? See here, these are the ovarian lesion. Like there is ovarian dysgenesis in case of Turner syndrome. Ovaries are not developed. They are called streaky ovary. Streaky. We can only see the fibrous band there. Okay, strict or streaky ovaries, and these ovaries are functionless. They don't have any function there, and without ovarian function, amenorrhea will occur. Polycystic ovarian syndrome, Steen-Leventhal syndrome. We have already discussed about that. It leads to anovulation. There is no ovulation there, and without ovulation, there is no menstruation. So it's a very easy to understand. Premature ovarian failure is another one. The definition is menopause occurring before the age of 40 years. This is known as premature ovarian failure. Androgen secreting ovarian tumor is another cause. Okay, like Sertoli Leydig cell tumor. They are the one which releases androgen, and androgens are antagonizing to the estrogen. Surgery like oophorectomy and ovarian suppression by pelvic irradiation in case of ovarian cancer. These are the treatment which are necessary. So if you remove the ovary, then amenorrhea will definitely occur. But at the same time, pelvic irradiation is one of the type of treatment of ovarian cancer. That irradiation may damage or suppress the ovarian function. So these are the causes of amenorrhea from ovarian side. Some other endocrine lesions can also lead to amenorrhea, like thyroid disorder. Both hypothyroidism and hyperthyroidism can result in menstrual cycle abnormalities or amenorrhea. Poorly controlled diabetes and even Cushing syndrome and advanced Addison's disease can result in that. Let's move on. Now, after listing these important causes, which are the important questions from the exam point of view, let's talk a little bit about the interesting causes here, and which are asked in their exam. Many students will be asked that question, whether you know the concept or not. So what is Mullerian agenesis, and what is really happening there? See there. The Mullerian duct, also known as, what is another name for Mullerian duct? Yes.
Sir, paramesonephric duct, sir.
Exactly. Very good. Paramesonephric duct. Paramesonephric duct is also known as Mullerian duct. Very good. So this duct is very much essential for the development of most of the inner genital organs of the female. Like lower part of the vagina is not formed by that, but most of the other structures are formed by that, okay, except ovaries. Now, genetically, these females, okay, are having, see that, what is the genotypic sex? They are normal female. 46XX means they are normal female. With idiopathic absence of the Mullerian duct derivative, like there is no fallopian tube, there's no uterus, no cervix, and no upper vagina. These all are formed by Mullerian duct. The lower vagina is there because it is originating from the urogenital sinus. So it may not be diagnosed in time. That is the point. Patient develops secondary sexual characteristics because ovarian function is intact. Remember, ovaries are not developed from Mullerian duct. The Mullerian duct, okay, do not give rise to ovary. That's the reason. So lady will develop pubertal signs and symptoms because of the hormonal effect, okay, but there will be no menstruation. There's normal pubic and axillary hair, and testosterone levels are also normal in female, okay. But regarding the management, surgical elongation of the vagina should be done for satisfactory sexual intercourse, and apart from that, nothing else can be done. You cannot, replace the uterus there. You cannot replace the cervix there. Okay, only some plastic surgery is done so that satisfactory sexual intercourse can happen in the future. So this lady can never become mother. She can never conceive. Let's move on. Now, another very interesting, cause is known as androgen insensitivity. Now, androgen insensitivity. Now, in some of the textbook, it is also mentioned as testicular feminization syndrome. Testicular feminization syndrome. So let me write that term here. Testicular feminization syndrome. Now, what is this? Now, genotypically, they are male. Genotypically, they are male. They are having Y chromosome. But what is the problem there? There is no receptor functions regarding androgen. So androgen is also present, but that androgen is not acting on the receptor level. So bodies do not respond to the high levels of androgen. This is the problem. That's why it is also known as testicular feminization syndrome. Without androgen stimulation, internal Wolffian duct structures atrophy. The Wolffian duct is also known as mesonephric duct. And remember, this mesonephric duct will give rise to some of the internal genital structures of the male, like vas deferens, okay, then epididymis, seminal vesicle. All of these are developed from Wolffian or mesonephric duct. So they will atrophy because of no stimulation. With testicular Mullerian inhibitory factor present, the Mullerian duct derivatives involute as well. So there's no role of Mullerian duct in case of male, right? Mullerian duct will involute, or it will disappear in male, and this is done by testicular Mullerian inhibitory factor. Without body recognition of dihydrotestosterone, the external genitalia differentiate in a female direction. Now, just now, I taught you about this intersex state. There are different terms in intersex state. One term is called true hermaphroditism. Other is called pseudo hermaphroditism. Now, what type of intersex state I call this? What is the proper term for this now? What is the genetic sex here? And what is the phenotypic sex? Yes, yes.
The pseudo-hermaphroditism.
Sir, pseudo hermaphrodite.
So which type of pseudo hermaphroditism? Is it male type or female type?
Sir, female type.
Okay, so how do you answer this? Okay, let me remind you again, then you will give the correct answer. Now, to label it as a male pseudo hermaphroditism or female pseudo hermaphroditism, we see genetic sex. We see genetic sex first. So what is the genetic sex here? It is a male, isn't it? This person is a male. So this is known as male pseudo hermaphroditism because the genetic sex present. Because there is androgen inside. What's the problem there? Androgen is not responsive to the receptor. So the external genitalia looks like female, but internally, according to the genotypic sex, this person is a male. So this is the wonderful example of male pseudo hermaphroditism, a testicular feminization syndrome or androgen insensitivity syndrome. Patient function psychologically and physically as female, and they are brought up as girls by the family because the external genitalia looks like female, and their overall behavior is a bit like female as well, because the male hormone is not acting at all. And of course, there is a little bit female hormone present inside the male body also. So that hormone will take over now, and a bit of feature will be like female. At puberty, when primary amenorrhea is noted, the diagnosis is made. There is no uterus, you know that. So how menstrual cycle will start, isn't it? It's impossible, because this person is basically a male. So when this occur, the family will take this girl. Actually, he's a boy, but is acting, or the external appearance is like a girl, will be taken to the gynecologist. And when they take a history, when they examine thoroughly all those different type of investigation, then the diagnosis is made. Female secondary sexual characteristics are present because the testes do secrete estrogen without competition from androgen. It's very nicely written. Okay, so some amount of secondary sexual characters of the female will develop in that person. No pubic or axillary hair is noted here. Now, do you know why there is no pubic or axillary hair in this case? Why? Who can answer this?
So, sir, because of androgen sensitivity, sir, because sir, these here for sir, the androgen is responsible. Sir, there is androgen sensitivity, sir, that's why
Very
like
good.
there is no pubic or axillary hair.
Very good, very good. Yeah, that's the point. That's the point I want to hear. Excellent. In female also, in female body also, okay, not only in the male body, in female body also, the pubic or the axillary hair growth is done by androgen. Remember this. But in this case, there is androgen insensitivity. So no pubic hair, no axillary hair growth is noted. Testosterone levels are, normal male. Okay. Now, regarding the management, testes removal at the age of 20, because the higher temperature associated with the intra-abdominal position of the testes may lead to testicular cancer. This is very, very important point. Remember, though external appearance is like a girl, this person is a male. So this person is having testes inside. The person is secreting testosterone, but that testosterone is not acting at the receptor level. That is the problem here. So we have to remove that testis, because though it is doing its job, but it is not showing the effect because of androgen insensitivity. So why to keep it inside? If we keep, okay, it may lead to a lot of problems. Otherwise, there is a high chance of development of testicular cancer later on. You all know that. That should be done. And after that, estrogen replacement is given, so that person is grown up as a female. Another condition which is related with amenorrhea is gonadal dysgenesis or Turner syndrome. Gonadal dysgenesis is caused by Turner syndrome very commonly. That is known as streaky ovary. Okay, the ovaries are not formed. Turner syndrome is 45X, 1X is deleted or absent. Okay, so because of absence of that 1X, there is no growth of ovarian follicle. Instead of developing ovary, the patient develop streak gonad. Now, a very interesting point you need to understand here is the negative feedback mechanism. So see this. Estrogen is not developed by the ovary, because ovaries are not there actually, you can say that. Okay, so there would be no estrogen released by the ovary. Without estrogen, the negative feedback given to the hypothalamus and pituitary is very poor. So from the pituitary side, more FSH is released. So this condition is associated with increased FSH in the blood, but there is a severe lack of estrogen. No secondary sexual characteristics are noted here, okay, because estrogen is not present. That is the point of Turner syndrome. Regarding the management, estrogen and progesterone replacement are given for the development of secondary sexual characteristics. So this much we can do. Because of the lack of ovaries, she will remain amenorrheic, and she cannot conceive. and she can never become mother. Let's move on. Now, another important, types of causes are hypothalamic pituitary failure. So we have listed that before. So let's talk a little bit about them. See there. In the patient without a secondary sexual characteristics, but uterus present by ultrasound, another possibility is the hypothalamic causes of amenorrhea, like stress, anxiety, anorexia nervosa, or even excessive exercise, like athlete. Okay, those women who do a lot of exercise, who are very active type of athlete, they may suffer from amenorrhea. So in them, the hypothalamus is dysfunctional. But when we look for the internal genital organs of the female, they are present. So in this condition, the FSH is low. Okay, FSH is low. There is one condition which is a part of this process, that is called Kalman syndrome. Now this Kalman syndrome is the inability of the hypothalamus to produce GnRH, and also there is anosmia. Anosmia, the person is unable to smell. Okay, lack of smell is called anosmia. So hypothalamic dysfunction along with anosmia is called Kalman syndrome. Now, without GnRH, the secondary sexual characteristics will not develop. Male will have a very small size of the penis, which is known as micropenis, and the different sexual characteristics are absent. Okay, in female also, the growth spurt will not occur, the breast development will be a problem, and menstruation will not occur. So these are the point. CNS imaging will rule out a brain tumor in this condition, because we have to rule out. Okay, pituitary tumor or brain tumor is one of the cause of amenorrhea. Regarding the management, you have to replace estrogen and progesterone for the development of secondary sexual characteristics here. Now, see here. Now, what are the common causes of secondary amenorrhea? You have, gone through so many different types of etiological points. So, what are the main one which students should not forget? They are pregnancy and ovulation, estrogen deficiency, and outflow tract lesion. Okay, so these are the main one, and other ones are some endocrine causes which are high up in the hypothalamus and pituitary. You can add a few of them there. The last one, or outflow tract lesion, is also known as cryptomenorrhea, because actually the menstruation is occurring, but it is not visible outside. Now, let's talk about the diagnosis, how to confirm it. The causes of primary and secondary amenorrhea may overlap with each other. Okay, so how to differentiate? In primary amenorrhea, there is no menarche. When we take the history, there is no menarche. There is no start of the menstruation at all. And secondary, there was menstrual cycle before, but now it is absent. This is the secondary one. Secondary amenorrhea indicates a patent lower genital tract, an endometrium which has responded to the ovarian hormone, and ovaries which have responded to the gonadotropin. These are very essential for secondary amenorrhea, because before this episode of amenorrhea, she was fine, everything was normal, and for the normal things to happen, we should need normal anatomical structure. They are genital tract, endometrium, and the ovaries, and we should have the normal level of gonadotropin as well. Exceptions of these include surgery to the endometrium or cervix, okay, which rarely cause intrauterine adhesions or cervical stenosis respectively, and then they can lead to problem. Now, some of the congenital disorder usually present as primary amenorrhea are, see this, okay, a little bit repetition for you now. Congenital malformations of the genital tract, testicular feminization, okay, also known as androgen insensitivity, gonadal dysgenesis, A perfect example is Turner syndrome. Congenital adrenal hyperplasia. This is a very important cause of, okay, female pseudohermaphroditism. Female pseudohermaphroditism. Now, why? Why, female pseudohermaphroditism? Because the genetic sex is female, okay, and the external appearance is like a male here. This is CAH. And hypogonadotropic hypogonadism is Kalman syndrome, because uh, the hypothalamus is not working properly. So these are, most of them are congenital. However, any cause of secondary amenorrhea may present as a primary amenorrhea if it occurs before the age of 16. So that's why they often overlap with each other. Now, please focus on this slide, okay, and try to get a concept here. Now, see this. These are the causes of primary amenorrhea, which we have just listed. Now, how to diagnose them? Which one is responsible, isn't it? We do certain examination. So, see this. Vaginal causes of primary amenorrhea, like vaginal agenesis and vaginal septum and imperforate hymen. Okay, both are the causes. Imperforate hymen and vaginal agenesis. Okay, these are the cause of cryptomenorrhea, actually. Cryptomenorrhea, but they look like primary amenorrhea. So we have listed it here. The breasts are present during examination, and uterus is also present. So this is a very important point here. Mullerian agenesis and androgen insensitivity or testicular feminization syndrome. We have presence of the breast but absence of the uterus. Why uterus is absent here? Anyone? Why uterus is absent in this case? Yes?
Sir, because of Mullerian agenesis, because of the Mullerian no. So the Mullerian or the paramesonephric also give rise to a part of the uterus. So sir, if it's agenesis and it's not built properly, so they'll be absent of uterus, I believe.
Exactly. Absolutely. Okay, very easy question, because we have been discussing this. Absolutely correct. Because Mullerian duct is not developed here. That is the meaning of Mullerian agenesis. So how can uterus be developed? So uterus will be absent, but development of the breast, okay, is done by estrogen. Estrogen is present here. Only problem is androgen insensitive. The last two, gonadal dysgenesis, Turner syndrome, or Kalman syndrome, which is a hypothalamo-pituitary ovarian axis failure. There is absence of the breast development, but uterus is present. Okay, uterus is already developed, but breasts are absent because there is no estrogen. Means breasts are not developed. Very small size breasts are only there. So these are the very important clues for us to distinguish which type or which causes of primary amenorrhea are present there. Now, some of the important history asks about the age of menarche and development of secondary sexual characteristics when you are taking the history. Absolutely important one. At what age they started to appear, and what age menarche occurred, or menarche did not occur till now. All these questions are important. Asks about the menstrual history in detail, including regularity of the cycle and any abrupt change. How was the cycle before? We have to ask that. How is the cycle now? What is the chief complaint? Why the lady has come to you? All these questions are important. Asks about personal or family history of hirsutism. Now, you all know hirsutism is a feature of excessive androgen, and androgen is the antagonizing hormone for estrogen. So that's why this hirsutism is an important question. And in case of hirsutism or in case of androgen excess, there is usually amenorrhea. Galactorrhea. Okay. What is galactorrhea? What is the meaning?
Sir, galactorrhea, sir, it is basically like, sir, sir, it's a sort of milky discharge from the female breast nipple, sir, basically.
Exactly. You're absolutely right. This is excessive milk discharge from the female breast. Okay. Even in those situations where it should not occur, like at the time of lactation, it is normal. Even in the later part of pregnancy, the breasts are very heavy. So But apart from them, apart from this situation, if there is a milk discharge from the breast, this is considered very abnormal. And usually it is associated with excessive prolactin release inside the body. Maybe prolactin secreting tumor in the pituitary, okay, or certain drugs which are causing excessive release of prolactin. And prolactin is causing the problem here. Headache and the visual symptom. These are the features of pituitary tumor. Pituitary tumor are associated with amenorrhea because of damage to the pituitary function. Headache and visual symptoms are caused by raised intracranial pressure as a result of pituitary tumor. Remember, tumor is a space occupying lesion. So it is present in the inside the cranial cavity. So the overall pressure in the cranial cavity is high. This is raised intracranial pressure. Headache and visual symptoms like blurring of the vision is very common. There is maybe vomiting also. There may be seizure also. There may be loss of consciousness also. It depends on how severely the intracranial pressure is high. Ask about the history of drug use like combined OCP, phenothiazine, metoclopramide, alpha-methyl dopa, and tricyclic antidepressant. All of these may be associated with amenorrhea. And one of the important action of these, they result in uh, galactorrhea or hyperprolactinemia, and some of them will give negative feedback to the release of gonadotropins like that. So we should ask which drug the lady is taking. Ask about the psychological history, or take the psychological history like recent emotional upset, shift to the new job, and regularity of the working hour. Because this is one of the important factor of amenorrhea, recent amenorrhea, especially the secondary amenorrhea in that girl or in that woman. Ask about the recent weight change, upside or down. Okay, up or down means both overweight or obesity as well as severe loss of weight are associated with amenorrhea. And ask about the exercise history. Very actively exercising female, okay, like an athlete, okay, they are also having amenorrhea because of again effect on the hypothalamus. Take the detailed history of symptoms of thyroid, adrenal, and pituitary disorders. Consider both hypothyroidism as well as hypothyroidism. Consider both Cushing syndrome as well as Addison's disease and pituitary disorder. Okay, the Cushing's and adrenal are the opposite of the condition from the adrenal side. Remember, Cushing syndrome means hypercortisolism, excessive level of cortisol, and Addison's disease is hypocortisolism. Take the history of symptoms and signs of diabetes, okay, and its control. Ask some quick questions like how to take history of diabetes. What questions you like to ask? Anyone? What question?
Sir, polyuria, polydipsia.
Very good. Polyuria, polydipsia, and polyphagia. These are classical symptoms of the diabetes, especially type 2 diabetes. Okay. Polyuria means excessive urine output. Polydipsia, increase thirst and increase water intake. And polyphagia is excessive eating. These are important features. And recent loss of weight is another important feature of diabetes. Asks about the gynecological operation the lady has done before. Who knows? This is a case of Asherman syndrome. Okay, that can be a possibility. And many gynecological operation can lead to Asherman syndrome. That is the development of extensive synechiae or adhesion inside the uterine cavity. Menarche and menstrual history of mother and sisters should be asked because some of the disorders may run in the family. Genetic defects in the family members has to be asked. And an easy way to ask is how is the health of other? How is the menstrual cycle of others? Are they fine? Just one question may be enough. And if somebody is not fine or well, they'll definitely tell you that. And then you can ask the detailed question. Asks about previous CNS chemotherapy or radiation exposure, that is pelvic radiation, because CNS chemotherapy may damage the pituitary gland and pelvic radiation therapy may damage the gonad. So these are some of the important historical questions. Now, what examination you like to do? Now, always examine for secondary sexual characteristics feature in that girl or female, like development of the breast or the development of the pubic hair. We always examine that. Okay. Now, breast development will be a problem if there is no release of estrogen. But pubic hair is developed mainly by androgen exposure. Record height and weight. Okay, record height and weight. Now, one important question I have to ask here: if the height of that girl is very, very short, okay, what condition you guess or suspect? Short height with amenorrhea. Yes.
Hypothyroidism, sir.
Good. One is hypothyroidism. Very good. Another one? Turner syndrome. Okay. Turner syndrome. Yes. In Turner syndrome, the lady is very short height. Remember that. And she is amenorrheic as well. So Turner syndrome and hypothyroidism. These are the two important conditions here. Even pituitary tumor, which is there from the very beginning, but that type of presentation can be diagnosed quite early. As a result of damage to the anterior pituitary or growth hormone releasing cells, sometimes that can be a cause of short stature or height. This height and weight are expressed as a percentage of ideal, means according to the comparison to the normal person, what is the decreased percentile. So we'll always tell like that, and if possible calculate BMI as well. This is BMI, body mass index, very easy to calculate. Every student know the formula of BMI. Features of gonadal dysgenesis should be examined. Okay, like Turner syndrome clinical feature. Now, can you list some of the clinical features of Turner syndrome here? Yes. What are those? One of the feature which is please. Yes.
Like sir, we've got.
Yes, please.
Sir, we've got different skeletal abnormalities as well, sir. Sir, as you said earlier, sir, we'll have sir the short stature, and sir, we will also have, sir, the neck webbing, sir, and sir, this neck webbing is known as the pterygium coli, sir.
Now see there. So some of the important feature he has mentioned. So let me tell you some more. Turner syndrome is lack of one X chromosome. So it is 45X not or 45X. So because of that one X, the gonads, the ovaries are not developed in the female. Because of that, a lot of other features will be there. That is lack of secondary sexual characteristics. You already know that. Okay. Then very short height. Remember, but she looks fine from outside. She looks fine. So we cannot diagnose her before the period of puberty. There is no menarche in this girl because the absence of ovaries. There is no menarche, no beginning of menstruation. On top of that, okay, she is having waving of the neck. Waving of the neck means very short neck, so that there is extra skin fold on the back of the neck or on the side of the neck. This is called waving of the neck. It is present right from the time of birth. Actually, if we pay attention, it is present at the time of birth. So when we examine that baby, we can suspect Turner syndrome right then. Another important clue is they have edema on the dorsum of the hand and feet. Edema on dorsum of the hand and feet. Okay, this is important one. This is lymphedema, because lymphatic channels are absent usually in a Turner syndrome girl. And they can also have different type of cysts which are filled with lymph. Okay, filled with lymph. Now, Some other clinical features are congenital heart disease. So which congenital heart disease is present in Turner syndrome? What is that? Yes?
Sir,
Coarctation of aorta.
quotation of aorta, sir.
Very good. Coarctation of the aorta. Coarctation of the aorta and even peripheral pulmonic stenosis. So these are the important problem in the cardiovascular system. And when we examine her chest, the breasts are quite wide apart in this girl, quite wide apart. This is another important clinical feature. So study Turner syndrome. What I'm saying here is probably, you cannot pick all the things what I am telling you right now, but I'm stimulating you for the, study of Turner syndrome here. That's the way. Examine for hirsutism. Okay, hirsutism. Now, examine the facial hair. In a girl, if there are lots of facial hair, that is called hirsutism. And sometimes the hair is also present on the upper side of the back, okay, and other place as well, where the hair should not be present. This is hirsutism. Examine for the evidence of thyroid, adrenal, and pituitary disorders. So many different signs are there, So let's not go into the detail. These are altogether very big topic in themselves. Now, a few of the picture I have included here from the different internet site. So see this. This is the anorexia nervosa. Look at the health of this girl or female. See this? I can see all the ribs from outside. Her breasts are also atrophied, and definitely this lady will have amenorrhea. Okay, will have amenorrhea. This is the imperforate hymen. There's no opening in the hymen, so this can lead to hematoculpus in the beginning and hematometra later on. So hematoculpus is a collection of blood clot in the vagina, and hematometra is in the uterine cavity. And the treatment is quite easy once you diagnose it. You just need to give the cruciate incision here, and the hymen should be opened, cut open. So this is the management. Sometimes this may be a cause of amenorrhea, but this is not a cryptomenorrhea. What are the other examination you like to do? Examine for breast, how well they are developed. If breast development is fine, then estrogen activity is proper. Okay. Examine for galacturia. When there is excessive, milk discharge, this is known as galacturia, and it suggests this is a case of hyperprolactinemia, and that is the cause of amenorrhea. So you can diagnose by a good type of examination. Examine for abdominal and pelvic cavity. Now, examine for the presence of uterus. Okay, we always do that. First, we do bimanual examination, and then we take the help of investigation. Ultrasound will clearly tell us whether uterus is there or not, whether ovaries are there or not. Okay. But remember one thing, a bimanual examination is inappropriate in young girls who are not sexually active. Okay. In a virgin girl or those girls who are not sexually active, you do not do bimanual examination, means per vaginal examination, bimanual. One of the hand is put inside the vagina, you all know that. Another hand is on the intra-abdominal wall, and we'll examine like that. So this is ethically, okay, not done. It is not done. We just inspect there. If there are some serious disorder which we think, then okay, under anesthesia, general anesthesia, with a consent taken from the family, then we may go for that. But it is not usually done. Examine for external genital appearance and the pubic hair. We do that all the time. Now, different example I can give here. If they are not developed, then there's a lack of secondary sexual characters. Okay, that is one suspicion. And another one, even female or male pseudohermaphroditism can be diagnosed by the examination of external genitalia. Female pseudohermaphroditism are having male external genitalia, whereas male pseudohermaphroditism are having female external genitalia. Okay, so remember that. Now, what investigation you like to do for the confirmation of diagnosis of amenorrhea? The congenital causes of amenorrhea can be ignored in patients with secondary amenorrhea, because if congenital causes are there, then they should cause primary amenorrhea, okay, usually. But a patient with primary amenorrhea may have any of the condition associated with primary or secondary amenorrhea. Now, if somebody is saying primary, of course, the menstruation will never occur, isn't it? So that's the point. And pregnancy must always be excluded. And you all know how to do that, right? It is done by urine pregnancy test. It's one of the easiest investigation we can order in the hospital. Now, this is important one, an important question from the exam point of view also. What are the investigation? Now let's list them. These are the basic investigation we do. We always start with history and physical examination. Though strictly speaking, these are not the investigation, but they are the part of our diagnostic process. That's why they are listed here. Always, history and physical examination will direct us which investigation to order. Measure different type of hormones. Okay, measure different type of hormones like prolactin level, FSH and LH, thyroid hormone, and testosterone level. So everything are connected with amenorrhea. That's why we have to measure them. Now, some of the important point here: luteinizing hormone or LH is often raised in polycystic ovarian syndrome, whereas FSH is not high in polycystic ovarian syndrome. On top of that, polycystic ovarian syndrome female are obese. They are also having hirsutism. So all these points combined together can give the diagnosis. An elevated serum FSH indicates ovarian failure. Now, ovarian failure means there is no function of ovary, no release of estrogen, no negative feedback. So FSH will be increasingly secreted from the pituitary side. Prolactin is raised by stress, prolactinoma, and secondary to some drugs like phenothiazine. Okay, phenothiazine. These are the antipsychotic drugs. They are dopamine antagonist. So that's why they can cause hyperprolactinemia. Another type of investigation is pelvic ultrasound. Always done. Very, very informative one. They indicate whether ovaries are present or not. First thing, how big are the ovaries? What is the size of the ovary? Okay, are there presence of follicle inside the ovary or not? And they also diagnose polycystic ovaries if they are there. They can also show uterus is there or not. Okay, and in this case of vaginal atresia, for example, they can show us whether uterus is present. Now let me clarify this. In vaginal atresia, okay, the menstruation is happening, but it is only collected in the uterine cavity. It is not coming outside because there is no formation of the vagina. Okay, so this will give you the diagnosis. If uterus is present, okay, if it is filled with blood clot, but vagina is absent, then we got the diagnosis. Oh, this is the problem for menstruation or amenorrhea. Now, what are the other investigations apart from them? Think about all those causes. Chromosomal study. If primary amenorrhea without any obvious basis, or if abnormal phenotype is there, go for the chromosomal study. The chromosomal study will diagnose all those chromosomal abnormality which may result in amenorrhea. Progesterone challenge is one of the tests which we do. Progesterone. Remember, progesterone is the hormone which will develop secretory change in the endometrial cavity. And if we stop that, it will lead to menstruation. Okay, so it can diagnose different type of hormonal imbalance. We are going to talk about that in the next few slides. Progesterone challenge test and estrogen and progesterone challenge test. Okay, radiological study like IVU, intravenous urogram, if uterine or vaginal malformation are there, and just to exclude associated renal abnormalities are there or not, we go for IVU. Sometimes one congenital anomaly may be associated with other. So this type of test may be necessary, but not done in every type of cases. CT or MRI are done to visualize pituitary fossa for tumor. Okay, especially MRI is done to diagnose pituitary tumor. Abdominal or pelvic CT scan or MRI are done for hematoculpus, hematometra, or other developmental anomaly. Now, see there? I just now discussed about this point, hematoculpus and hematometra. Now, let me ask you whether you have, heard this discussion nicely or not. These hematoculpus and hematometra are seen in which condition? Yes?
Imperforate hymen, sir.
Excellent.
Vaginal atresia.
Very good. Vaginal atresia and imperforate hymen. Now, if I ask hematometra, then you can say vaginal atresia. But if I ask hematoculpus and hematometra, then vagina should be there. Okay, vagina should be there. Otherwise, there is no term called hematoculpus. So you got the meaning. So these are the important questions from the exam point of view. Excellent. Laparoscopy and gonadal biopsy can be taken. Okay. Gonadal biopsy should be done, especially in the intersex state, whether what type of sex is there inside, what type of gonad is there. Sometimes it may be necessary. And hysteroscopy, especially done in case of Asherman syndrome. Asherman syndrome can be diagnosed by hysteroscopy. We can directly visualize the uterine cavity, and if we see a lot of adhesions there, you got the diagnosis. Now, what is this progesterone challenge, and what is this estrogen progesterone challenge? Okay, so let's highlight on it. For the progesterone challenge, we give a type of progesterone which is known as medroxyprogesterone acetate, MPA. It is given at 10 milligram per day per oral for 5 days. So this is the type of progesterone. If withdrawal bleeding occurs 5 to 7 days later, then the endometrium must have been previously exposed to adequate levels of estrogen. So this is the conclusion or interpretation. Now let me clarify again. Only progesterone is not going to do its job. Before progesterone is given, estrogen should be present there, and that endometrium should be converted into proliferative type of endometrium. Then only on top of that, progesterone can convert it into the secretory type. So if the after stoppage of the progesterone, if bleeding occurs, that means estrogen has already done its job before. That's how progesterone can also do the job. So that is the interpretation. Polycystic ovarian syndrome and hypothalamic dysfunction are the most likely cause of the amenorrhea, the former being indicated by polycystic ovaries and ultrasound scan. This is just they are talking about some of the causes of amenorrhea here. But this type of test is important just to know whether estrogen was there or not before. Now, what is estrogen progesterone challenge then? See here, if no withdrawal bleeding occurs, okay, after stoppage of the progesterone, give estrogen prior to medroxyprogesterone acetate. A typical regime would be ethinyl estradiol, this is a type of estrogen, 50 microgram daily for 21 days, with medroxyprogesterone acetate 10 milligram daily on days 16 to 21. So we give both estrogen and progesterone here. Okay, progesterone is given only from 16 to 21 days. Withdrawal bleeding indicates an estrogen deficiency state. This may be due to ovarian failure, indicated by raised FSH, or hypothalamic pituitary failure. So these are the causes of estrogen deficiency in this case. Now let me clarify this. Maybe you are a bit of confused here. Now see this. We just check whether withdrawal bleeding occurs or not. Now we are giving estrogen here, and after that we are giving progesterone. Remember, this is a case of amenorrhea. Okay, in amenorrhea there is no menstruation normally. That's why this lady has come to us. So we are checking what is the cause of this amenorrhea. So to find it out, we give estrogen first, okay, for 21 days, and in the later stage we give progesterone along with estrogen. So if the withdrawal bleeding occurs after the stoppage of this drug, that means, yes, there was a deficiency of estrogen. That's why the proliferative endometrium can never develop. This is the conclusion. No withdrawal bleeding after the estrogen progesterone regime indicates a uterine disorder. Okay, so these are some of the important, concept here. Now see here, this table is a very summarized version of the important points regarding diagnosis. Certain points, from the history and certain from the physical examination. See this. When we ask about the development history and the onset of menarche, okay, if they are delayed, or if they are incomplete, then we think about congenital malformation or chromosomal abnormality. We take a detailed information about the menstrual history, and if these are the relevant factors like oligomenorrhea or secondary amenorrhea, then we think about these as a possible diagnosis like polycystic ovarian syndrome or premature ovarian failure. POF is premature ovarian failure. Take detailed history about the reproductive, function. If the lady is infertile from the beginning, okay, then it may be a case of, again, polycystic ovarian syndrome or some congenital malformation where there is a Mullerian agenesis, there is no development of the uterus. Cyclical symptoms like cyclical pain are there, but without menstrual flow. You all know this is known as cryptomenorrhea. So probably imperforate hymen or vaginal atresia may be responsible. Hair growth, which is known as hirsutism, okay, is a classical features of polycystic, okay, ovarian syndrome. Weight, whether there is a dramatic weight loss or difficulty losing weight, it may show different type of things. Dramatic weight loss may result in hypothalamic malfunction, like anorexia nervosa, a very stressful condition, all those things. And difficulty losing weight or overweight or obesity is classical features of polycystic ovarian syndrome. Lifestyle asks about the exercise and stressful condition, which may result in amenorrhea by causing hypothalamic dysfunction or malfunction. Asks about the past medical history, like some systemic disease in the past. One of the examples is sarcoidosis. It is known as neurosarcoidosis if it affects the brain. Past surgical history should be asked, like whether any surgery done in the uterus or not. That can result in Asherman syndrome. Asherman syndrome is, adhesion developing inside the uterine cavity. It asks about the drug history, which drug the lady was taking in the past or right now. Important example are dopamine agonist and hormone replacement therapy. Okay, they can again cause hypothalamic malfunction. Headache, galactorrhea, and visual disturbance. All of these are seen in some pituitary tumor, and those pituitary tumor may be functioning type of pituitary tumor or a non-functioning type. Okay, any types may be there. Functioning, one of the good example is prolactinoma, because it releases prolactin hormone, which causes galactorrhea, and that is the cause of infertility. So these are very, very important point. This is like a summarized version of what we have discussed till now regarding the diagnosis. Now the final part is the treatment. The treatment depends on the cause. What is the cause of this amenorrhea? The treatment really depends on that. But still, let's talk about some general points. Now, see here, these are the cause of amenorrhea or oligomenorrhea. These are the management you like to do. Low BMI, very lean and thin girl or female, okay, extreme loss of weight, low BMI, less than 18 is called malnutrition according to BMI classification. We give dietary advice and support. And if she is taking good nutrition, then everything may come back to the normal. Hypothalamic lesions like glioma, this is a type of tumor, surgery should be done. Hyperprolactinemia or prolactinoma, okay, one of the option is surgery, another is use of the medicine like dopamine agonist, bromocriptine or cabergoline. or if they fail, surgery should be done. Remember the relation between dopamine and prolactin. See this? These are agonist drug. Okay, so they almost acts like a dopamine, and dopamine is an inhibitor of prolactin. Never forget that relation. Premature ovarian failure, we give hormone replacement therapy, HRT, hormone replacement therapy, or combined oral contraceptive pill. Combined oral contraceptive pill. Polycystic ovarian syndrome. Okay, we have already discussed about this. Now, let me ask this: how you manage a case of polycystic ovarian syndrome? Yes, how you manage?
So,
yes, please. What do you do? Anybody? We induce ovulation by using certain drugs like clomiphene or
metformin.
GnRH. Exactly, clomiphene or GnRH analog. We try to induce it. Induce the ovulation. Another is surgery. Surgery is also a part of this polycystic ovarian syndrome treatment. Now, to inhibit the effect of androgen, different anti-androgen drugs also can be used. See that this is a concept, if you just answer like that, nobody is going into detail and dig there, just answer some superficial point in gynecology. Asherman syndrome, we do adhesiolysis because there is adhesion inside the uterine cavity. So break down those adhesion known as adhesiolysis, and IUD insertion at the time of hysteroscopy to prevent the recurrence of adhesion. This is intrauterine device. Cervical stenosis, if it is there, which results in cryptomenorrhea, actually, hysteroscopy and cervical dilatation should be done. So these are some of the management which are listed here. This gives you a good concept, how to answer. It depends on the cause. Now, some more. Patients with congenital abnormality may be treated surgically with plastic surgery or plastic procedure to allow menses in those with a functional uterus or to create a functional vagina. It depends what is absent there. Okay, if a uterus is absent, then menses cannot happen, can never happen, isn't it? So this is a big type of congenital anomaly. But if lower part of the vagina or vagina is absent, then they may create a functional vagina. These are called plastic procedures. Patient with absent uterus and breast can be treated with estrogen replacement to effect the breast development and prevent osteoporosis. Uterus is absent, so that lady is, amenorrheic, and the lady is infertile. There is no uterus, so how can she be pregnant? Okay, so this is the one important point. And another one, breast development can be still stimulated by the replacement of estrogen, and estrogen can also prevent from osteoporosis. So estrogen replacement is given in them. Patients who have breast development but an absent uterus may not require any medical intervention because they already have estrogen in them. Without estrogen, breast was not developed, remember? So estrogen is already there. You don't need to give any estrogen from outside. If the cause is uncertain and either the patient wishes to become pregnant or is anxious about the amenorrhea, ovulation may be induced using clomiphene, pulsatile GnRH, or human gonadotropin. We can give a trial of this drug, and if we are successful, probably the problem lies in the lack of gonadotropins. That's why the lady was amenorrheic and infertile. Okay. So at the end, I like to request you all to like the video as much as possible, share it among your friends, and subscribe to the channel so that it will encourage me a lot for the future videos and recordings. Thank you so much.